I'll call this meeting to order. The first thing we have is a public hearing for taxing budget for fiscal year 2027 and open for any comments from the group here.
No comment.
I'm not ready.
Nope.
Hearing none, do I ask for a motion to close the public hearing?
We'll see ya.
Okay.
So moved. Second.
The public hearing is officially closed then. I'll call to order our regular Board of Trustee meeting. We have a quorum present. The first thing on our agenda is consideration of the approval of the 26-27 budget certificate of tax from Christie.
So for the tax year beginning July 1 of 2026, just to give you a little bit of history, we kind of talked about this at the last meeting, was right now, if you look at our tax rate here, we're 8th lowest in the state at currently, based on the current property tax rate that's assessed by all county hospitals in the state of Iowa. If we look at it based on dollars levied, we are the 7th lowest in the state currently, at just a little over $1 million. Moving forward to 26-27, our property valuations that we use for the hospital county taxes increased to 1.16 billion, so it went up 51.9 million. We are requesting, we did publish to bring our total tax rate from 0.94711 per $1,000 of taxable valuation to $1.03323, which is a 0.08612 cent per $1,000 taxable valuation increase. We assess taxes for ambulance support a little bit there. That has decreased. From the last few years, it does increase a little bit each year just based on that. Property tax that we will get for operations, and it's in our general operating funding and Social Security funding that we can assess for. We can assess for lots of other things, but we choose not to. So that would be, we'll see a $5,000 increase in our ambulance tax and $135,651 increase in our property taxes for those other funding sources. The maximum budget, we put a maximum budget out there as $90,880,000. That is more than we spend, but because we necessarily don't want to have to amend our budget in the future, and our budget is not as dependent on our taxes, it's more dependent on our revenues. We always ask for a higher amount just to keep from having to amend our budget. Any questions on that? This new rate, based on the current rate, we're still the 11th lowest in the state. So assuming that, most entities either assess a little more or raise their rate a little bit, we're not raising our rate. The raise is not significant in placing us in a higher bracket than anyone else in the state. So I would basically, we have to approve this, and we'll file it with the county auditor, and then it will get approved by the state.
Okay, any questions for Christie? If not, I will consider a motion to approve the 26-27 budget.
I would make that motion.
Second,
I'll second.
all in favor? Aye. Motion passed. The next item on our agenda is consent for approval of our agenda for today. The minutes of our last meeting on January 27th, the special meeting we had on February 11th, approval of credentialing applications, and approval of monthly payroll claims, and all those were included in your packet. there any questions of that?
I'll make a motion to approve the
Jim,
consent.
thank you. Second?
I'll second that.
Okay. All in favor, say aye.
Aye.
Motion has passed. We have a report from Dr. Devine regarding the medical staff.
Yeah, med staff summary, this will be from February 10th. Laura went through our ACO measures. We're actually doing quite well. Our A1Cs, and you got to remember this includes people who don't do what we tell them to do, are at 88%. So we're doing pretty well. Breast cancer screening's at 75% of all eligible. Colon cancer screening we still have to work on and convince people that colonoscopies are a good thing. But that is one that we're working on hard. But still, it is respectable. Nicole then reviewed proposed changes to the heparin protocol. Several of us worked on that. It's to help with accuracy. So when we do heparin, it's usually a weight-based. Not everybody's ideal body weight. So we need to have a little bit of math to make it right so that we don't have things go over or under and get it right. So we worked a little bit on that. We also worked a little bit on the heated high flow policy. Heated high flow, we used quite a bit during COVID for adults, but we used it mostly for kids with RSV. It's a little bit of a CPAP, but it has humidity coming through coils warmed to try to break up mucus secretions and then get the airway moving better. When that's going through, since you're getting a little bit of pressure with it, it's hard to eat. So we want to make sure that we have IVs started early before they get dehydrated. And so our protocol now includes IV fluids just to keep things so that we don't run into trouble. We can do estradiol and progesterone testing in-house now. We have mental health, then discussed that we have a new therapist, Victoria Griffin, who started on February 17th and sees adults and kids. The current wait list is significant, so the goal is to work through those. They also, while we're trying to work through those, to give us some other local resources we can use in the interim, which was very nice to have available. We had a discussion regarding doing mid-level care at the nursing homes. This is becoming a popular thing, so the nursing home is usually a larger conglomerate of nursing homes. They hire their own mid-level to do acute care within the home. It is good in that they get the answer right away and those people don't have to be moved over to be seen. But it is kind of bad in that then when they come to the ER, we don't know what's been going on and they've lost that continuity. So we had a big discussion regarding that. We want to try to get working with them so that when they do institute this, that these people will contact the primary and make sure that everybody's on the same page. Because our people we still care about them when they go to the nursing home, so that's important.
Is that information on my chart then for each of those, or not necessarily?
No, because most of the nursing homes are not on
Oh,
Epic,
okay.
so they won't be on my chart. It is good, like I said, that they can be treated right then in-house, but we don't want to lose track and then show up in crisis and not know what's going on. That would be the bigger problem. We discussed fit testing versus guaiac studies. Guaiac is any blood. So if you have a raw hamburger or medium rare steak, it'll show up on that test as blood. A fit test is an immunochemical for human blood. So if you do that test on a stool, you'll know that, okay, there's something going on there. So we are replacing all of our regular guaiacs with fit tests, just so we have a little more accuracy. The next thing was that, and Jeff will talk more about this, but we did get a grant to do in-house MRI as part of the Rural Cancer Access and Prevention, which means that we will be able to also do prostate MRIs and breast MRIs once this is all put into place, which we see way too much cancer in the county, so this is really important, I think, for our clientele as a whole. Otherwise, and then we also talked about improving programs for that. We had the appointments and reappointments, and those were all approved by our med staff. And that concluded our February 10th meeting. Any questions?
I just have a question on those satellite hospital or nursing home mid-levels.
Yes.
How many is that happening in? Like
Right now in our region, it's in one, but there are at least two more looking at it.
Okay.
Partly because of the corporation. It's cheaper for them to do that than to try to have somebody also, faxing all night long and trying to get answers back and not getting them in a timely fashion. It's more efficient for them.
Sure.
And then they can bill for those visits as well. So as long as we can keep the continuity, I think it will work. It's just, we've been used to kind of almost a concierge type care where we take them from the beginning to the end. And we don't want to lose that.
Is there an opportunity for us at that level then to supply someone to do that?
What do you think cost-wise? I think that they probably will want to do it themselves just because it'll be cheaper for them.
Yeah, I don't think it's economically viable for us to do that also.
Any other further questions for Dr. Devine? Thank you. The next report from Cheryl Ferry will be deferred. She's not available today. And Laura, do you have a
Yeah,
UI report?
yeah, just a few additional highlights from January's meeting. OB reported a 0% C-section rate, which is excellent. Our team monitored patient teaching for post-surgical patients was at 100%. Rehab monitored prompt evaluations following approved authorizations, just getting those patients in promptly. And specialty clinic is closely monitoring pre-op and post-op data for both hip and knee replacements and really kind of tracking these patients over a year's time and seeing how they improve with their overall motion. We're finalizing our reporting to CMS for calendar year 2025, which is going well, which is what Dr. Devine alluded to with the A1C, colon cancer, breast cancer. That all gets reported and is through our ACO to CMS. And our next QI meeting is March 11th. So that's all I have.
Any questions? Thanks, Laura. We have some additional administrative reports. Nicole?
Yeah, so from a joint conference standpoint, we met on February 4th. Jenny Lefebvre reported on, or Kathy Buman reported on disaster planning and just talked about how the city had held their first meeting Monday, February 2nd to discuss RAGBRAI and what that might look like for us here. And Kathy and Jenny Lefebvre were able to attend that. Jenny reported on trauma, and we will be due to recert our level 4 trauma in May this year, and then they'll likely have a site visit in September or October. Jenny also reported that we're likely to get the AHA Gold Plus Stroke Award, as we've gotten in the past, and also from a cardiac standpoint feels like we'll meet the Gold STEMI or the Gold Plus STEMI and the Royal Chest Pain Awards that we've had in the past as well. So those are, it really looks at the data of those stroke and cardiac chest pain patients that are coming in and like if we're meeting the guidelines for criteria of getting them out of here to a higher level of care. So that's fantastic to hear that hopefully we will be getting those awards again this year. And then from a pediatric standpoint, Bailey Ertz, as I've mentioned in the past, is on our nursing clinical ladder, and she has enrolled us in a quality initiative called NPQRI. So we input a lot of our pediatric data, all of our pediatric visits from the ED will go in there, and then that would allow that national group to kind of look at and see if we have any room for improvement in certain areas. So she has started doing that. Jason reported for lab. We did have a proficiency failure with our fibrinogen testing. We met for 541 out of 550 tests were reviewed. No patients were affected, and we did submit an action plan to CLIA, which was accepted. So ultimately, we don't do a lot of fibrinogen testing in-house. So we had 5 tests, and 3 of those failed. And so we are just going to do QI on that machine more frequently than it's necessary to do, just so that we can catch that, since we don't run those tests all that often. Nancy reported for pharmacy, we're just reviewing our formulary to ensure that it aligns with our 340B program. And then we went through all of the policy and procedure reviews, which you could find in your packet, I believe, starting on page 18. We had no EPIC order sets to review, and then Laura reported on core measures and stated that our quality results are currently at 72% and customer service at 92%. and our next meeting will be May 6th. So I just need consideration of approval for the Joint Conference Committee Policy and Procedures revision.
I'll make a motion to approve the policy and procedure revisions as presented.
All in favor, say aye.
Aye.
Aye. Motion is passed. Kim Burchett has a report.
So, actually today, as we speak, the last person is moving from the existing clinic into their new remodeled space. That's the immunization folks. So they'll be the front and center of Pod A. So the rest will be completely turned over to construction. And, yeah, they can make their mess.
And noise.
And the noise,
And
right.
noise.
The Omnicell that you guys had approved back a few months for us to have one within the clinic walls has been set. It's not officially in use yet. We'll need the training and get everything completely set up through Nancy and Pharmacy, but we're looking forward to that as well. Otherwise, everybody's occupying the new space. Things are going well.
Good to hear.
Yeah. Patients are loving the new,
They are liking it.
that's good.
Not too much turmoil with moving from A to B and noise.
There's a little bit of a noise, you know, with them kind of the demolition within the A, but there's enough of the space that it really kind of diminishes that sound. Registration probably hears it more than the folks seeing patients in the back, just because it happens to be right directly behind them.
Okay, any further questions for Kim? If not, we'll get a report from Jill, HR.
Yeah, so Dr. Devine mentioned that we did receive some grant funding for our in-house MRI. So we had actually applied for 4 different grants through the state of Iowa's Healthy Hometown Initiative, and that was aligned with a federal, the Health Transformation Grant Program. And so we received just over $2.5 million worth of grant funding for that, and 2 of those grants will be to help us enhance our recruitment efforts. So one being recruitment of a provider, focused on maternal and child health needs in our community and our surrounding areas that we serve. And the other being to help us recruit for an additional registered nurse. That registered nurse position would be to assist us with the coordination of care, primarily in obstetrics and gynecologic services, serve as like a patient triage coordination with other specialty providers, but also assist us in that care coordination across our organization. So we continue to recruit for either a family medicine physician with OB who performs C-section or an OBGYN. So those efforts continue, and we're recruiting for a position currently that serves as that care coordination function for us. I also just wanted to let the board and the public know that we will be conducting our, it's our annual, but it happens every 3 years, community health needs assessment. So survey will be going out. We welcome the community to participate in that. So those questions will be going out, and that survey will close on April 3rd. And then we will be inviting the public back for a forum here at Myrtue in June.
How do they get that survey?
So the survey will be going out via social media, but we're also going to be, working with the school as well this year. It will also go out in the paper, but we provide that survey in a number of different ways.
So it's like a website they would go to compare?
It's a survey monkey.
It's a survey, yeah.
Okay.
It'll be a QR code also, Jim, so a lot of people, and I think we're planning on kind of setting them up in the clinics as well, so if you're sitting there waiting for an appointment,
You can do it then?
Yep.
That's great.
Good idea.
Yeah, that
It's
is
just
a
a
good idea.
little easier to get it out.
Yeah, we had about 120 people participate 3 years ago, and we would certainly like to see that increase. Kyle, though, assured us that's a good number.
The hospital I came from, our community health needs assessment, I would have loved to have gotten 120 responses. We averaged like 30, 40. A good year was 50. So
What's the window again from when it opens and?
So it's open, we'll be opening it. A press release will go out this week. It will close on April 3rd.
Okay. Write it down. All right, any questions for Jill? If not, move on to Jeff,
All right,
Information Officer.
coming up in a week, daylight savings time starts on March 8th, so
Yay.
just so everybody's aware, snuck up on me, found out this morning early, so. Anyway, a few other updates, the printers are continuing to be placed, rolled out. A couple of them didn't have fax cards, so we're getting the fax cards in to get them deployed. M365, tomorrow is an education session, we're going to record. We're going to try and get as many people as we can at that session, but then the recording will allow anybody to watch at their convenience. Want everybody to go through that before we transition, because there is some account setup that each individual will have to do, but it's pretty easy. It's just now a matter of time to transition everybody into it. I think we have probably close to 10% already done prior to the training as our testers. So haven't heard really any issues going on with that. Windows 11 continues. We're probably half the machines or so throughout the facility are upgraded to Windows 11, which puts us about 250. So we have about that same amount left to upgrade. As Kim mentioned, construction's continuing. They're going to, next week I believe, lay flooring up on inpatient rooms 224, 225. So things are progressing well there. As she mentioned, the last individual that was in the existing clinic is being moved, so all of that will be demoed. They are starting to paint and put final coats up on the second floor, so things are progressing well there. As Dr. Devine mentioned, the MRI grant we received, Friday is our kickoff meeting with the architect and the construction manager. We actually had a conceptual design back in May, so we're going to pick up there and continue moving forward. At the same time, Carrie and her staff are doing site visits to the three big places with the three big manufacturers of MRIs, so we can make an educated decision on which MRI we really want to have. Last thing I have pertains to substantial completion on phase 1 of the clinic build. We split the project kind of into 2 phases. Phase 1 is the new construction where we're currently occupying. We had performance guarantees and the whole 9 yards on that we wanted that done in order for us to move in to vacate the existing clinic for remodeling. We have worked with the architect and the construction manager and have agreed upon December 15th as substantial completion of phase 1. What that does, that allows the warranty period to start effective that day. So
December 15th.
December 15th last year,
Last
25. Year. Yep. So we've had a target of November 14th. Obviously did not make that. We opened on January 12th, but that was our decision. We really feel that December 15th was the time we could have actually got in the space and performed the functions as it was designed. But because of the holidays and a number of other reasons, we chose to open on January 12th. So, and with that, I would need approval to accept December 15th as substantial completion.
So motion for substantial completion of phase 1.
I would move the substantial conclusion of phase 1.
Carrie made a motion, second.
Second.
All in favor?
Aye.
Aye.
Motion is passed.
Okay.
That's all I had. Does anybody have any questions?
Everything seemed to be on schedule otherwise?
For the most part, yes. April 14th is the date where the entire project is to be completed. We have one change out that we don't have any information back on yet that may affect, probably will affect that date, but it's adding 2 more bathrooms, a procedure room, and remodeling reception up on the second floor of the existing clinic that would better create a more beneficial patient experience on the second floor. Plus, putting an additional procedure in, it'll be in hospital space instead of clinic space, so that creates a number of opportunities for reimbursements of procedures, and having it close to that space, because Dr. Kelly Anderson would use it, the behavioral health providers would use that space. Instead of walking all the way over to the surgical suites to do those procedures, we can do them closer in that space. So that may, more than likely, will affect the completion date.
So your proposed phase, is that then called phase 2?
Yes, correct.
Okay, Kyle, any report?
Sure. I'm just letting you know of a project we're launching here. I'm going to telling the managers about it in our meeting to follow today at 2. If I say HIT, it's because that's what it was called at our old facility, but here it's MIT, the Myrtue Improvement Teams. So this document goes over the purpose of the teams. It's to improve the organization culture by revamping or creating processes that directly or indirectly affect customer service and employee engagement. It will ask managers to submit employees from their departments for consideration to join the committee. No management is allowed on it. It is frontline employees only. The senior administrative team will decide what the project's going to be. The first one is going to be our standards of behavior or standards of excellence, and allowing them to revamp it. Of course, it will be approved ultimately by us, but however, we'll give them several examples of standards of behaviors or excellence from other facilities, including one I used to work at. They can pull from that or create a whole cloth and present that. The committee's purpose is to only stay in existence until that project is done. If we come up with a new project, it would be a new committee. That way you're turning it over. All employees get to feel ownership. But this document just explains it. And then this one talks about responsibilities of the team. Actually, I think it's out of order. But anyway, the next one was there's another document that talks about responsibilities and what they're expected to do within the team. I'm not going to read through it, all of it, but I just want you to be aware of what project we're launching here. And then we give them an example of the first agenda. The first agenda or the first meeting would be ran by myself this time around until I hand it off to somebody else to explain the project to somebody, tell them how it works, and help them elect a chairperson and set up officers. And then the next time around, it just provides them with an ongoing meeting agenda, because more than likely the people on the committee, a lot of them are not ever going to run a thing or have been in charge of something. Gives them a brief minutes document that they can keep minutes on, and also who's responsible for what action and when it's due, just the basic stuff. Then they're going to be required to, either their chairperson or somebody else be elected to bring a progress report to the administrative team every so often. These projects won't have a timeline. It could take 4 months, it could take 2 weeks. It just depends on the project and how often they can meet. Because the other thing is they're going to be meeting during working hours. So the managers are going to have to be expected to understand that if they're elected to this committee, they're going to have an hour every so often to attend.
How many members?
5 members, 2 alternates. So they will go through and submit. If you read it, if I gave you time to read it, which I didn't, they can submit a max of 1 possible member per 10 employees in their department. So the more employees you have, the more people you can submit for consideration. However, when it's looked at, we're going to try very hard to get a cross-section. You don't want 5 nurses, right? So you're going to have a nurse, you're going to have a housekeeper, you're going to have somebody for kitchen. You're going to try and get a cross-section of your entire facility, physical therapy, whatever. And the reason why you have 2 alternates is because inevitably somebody falls off or doesn't show up or turns out to be not as committed to the process, whatever, so you have to replace them. So that's just information on something we're launching. Outside of that, the only thing I have to report is that the EMS contract renegotiation is settled, and we'll be getting that signed by their board.
Are there any questions or comments? Kyle?
If you want to be bored to death, you can come talk to me about the MIT project. I'll talk ad nauseam.
Could you send it out so we can read through it?
Sure.
That would be good.
After I make a few corrections that I found while I was sitting here.
Perfect.
But you'll only have one myth going on at a time, is that what you're predicting?
Yes, for the first time around, but potentially you could have 3 of them going if there's 3 different projects that senior management wanted, senior admin team wanted input from employees on. And just in the past, it's been things like the standards of excellence in the place I worked, or you do the dress code, because the dress code is always the most controversial. And if you allow them to have input, they can't really then be upset when the dress code is something they don't like.
Good approach.
Yeah. Well, they can be, and they will be upset, but they have less ground to stand on.
You'll never have 100% pass.
Correct.
Christy, you have a report for us then?
Okay, going through the January financial reports, comparing the 1 month ended January 31st, 26 to last year, January 31st, 25, and then the 7 months for the same period, 26 and 25. So for outpatient visits, most of our visits here for the month of January were down a little bit. Could be, a lot of it could have been construction, could have been, we moved in January, we were closed for a while for behavioral health. So that's what it appears to look like, that the decreases in January of this year compared to January of last year. So we had 4,841 outpatient visits, 457 emergency room visits. Surgical procedures were 127. 3,570 physician clinic visits. The mental health clinic visits were 1,053. Our average daily census was 5.53 patients per day. We had 8 births, 5.3 million in operating revenue, 5.4 million in operating expenses. We did have an interest payment there, which we'll start seeing that a little bit more in that non-operating net. So we had a loss in January 26 of $125,848, and last year in January 25 we had a revenue of a net income of $183,000. Year to date for 7 months, we have seen 36,410 people in our outpatient service areas, which is a 1.8% increase. Our emergency room visits, we are at 3,639, which is a 6% increase from last year. Surgical procedures is 943 compared to 805. We're up 17.1%. Physician clinic visits, we were at 25,635, which is a 2.7% decline from what we were the 7 months of last year. Mental health clinic visits, we were at 8,112, which is a 0.8% decline from the previous year. Again, the move has affected those two probably the most. Average daily census, we were at 6.7 compared to 7.3, so we're down 8.6% for our average daily census. Our births are pretty consistent. We've had 64 compared to 66 last year. Our operating revenues are at almost 40 million compared to 36 million last year. We're at 11.3% increase. Operating expenses are 37 million compared to 34, up 8.1%. So year to date, and then you can see there our net operating our non-operating net is down to 769 compared to 1,347,000 last year. That's mostly the interest on our CDs and stuff that we have used for our construction projects. So year-to-date, we're at net income of 3.7 million this year compared to 3.3 million last year, 23.7% increase. If we look at this last 4 years comparable, from 2023, so the first 7 months of the last 4 years, you can see there in outpatient visits, we went from 32,938 in 2023, compared to 26 is 36,410. Emergency room visits, we went from 3,416 to 3,639. Surgical procedures, we went from 808 in 23, consistently up there pretty much, to 943. Physician clinic visits have increased from 24,947 in 23 to 25,635. Mental health clinic visits have seen a decline, 9,486 compared to 8,112. Average daily census is declined from 9.3 patients per day to 6.7 patients per day. Births have increased from 55 to 64. And just look at our bottom line, we net income from all sources, 1.2 million in 23 and 3.7 million in 2026. Again, the big portion of that is the Medicaid directed payments. The full financial reports are in your packet. And you can, as you look at that, you can see that our current assets, which are CDs and such, have declined, but our construction costs, our facilities have increased, and really our payables have not increased as much as our investment because we're using those receipts. So we have closed out the first $10 million in debt for the drawn down the first $10 million for this construction project, and we'll be beginning our monthly payments for that loan, and then we'll be looking at pulling the other $2 million in March. So we'll discuss that next month. Any questions?
You need a motion for the January 2026 financial statement.
So moved.
A motion and a second. All in favor? Aye.
Aye.
Is there any other business that needs to be brought forth to our meeting? No. The upcoming committee meetings are noted there at the bottom of the agenda. If there's nothing else, I'll take a motion for adjournment.
So moved.
Second.
Aye.
All in favor, say aye.
Aye.
Motion has carried.